Okay. I think we're recording. It says we're live. That means we're recording, right? Hopefully.
Hi, are we all on?
I think so.
All right.
I'll go ahead.
All right, go ahead and start.
All right. So for our ethical and legal challenges role play, the background information for us would be, for group 1, would be scenario 2. You are the preceptor for a student, family nurse practitioner named Ruth. Ruth is in a patient room with an elderly woman, Donna, who's been diagnosed with COPD and is very anxious. Ruth comes out of the room only after a moment or two and tells you the patient has asked Ruth to pray with her. Ruth states, "I'm not religious. I'm not going to pray with this patient." You've seen Donna before, and you know she's a devout Catholic. Donna keeps a prayer card at her bedside, and she asks her caregivers to read it because her eyesight is very poor. How will you respond to Ruth? And then the second part of our presentation, myself and Erin will be reading a role play enactment between the preceptor and the student. I'll be the preceptor and Erin will be Ruth. So how is Donna today? Yesterday she was experiencing a lot of anxiety. Did she ask for her PRN lorazepam this morning? Has her anxiety improved?
She asked me to pray for her. I don't want to pray for her. I'm not religious. Is it something I have to do?
Well, no, this is not something that you must do. Let's look at it further. It sounds like her request made you uncomfortable.
Yeah, I wish she wouldn't have asked me to do that.
What does prayer mean to you?
It doesn't really mean anything to me. Ever since my little brother died in a bike accident, I just can't believe in a God.
I am so sorry to hear about your brother. That must have been really difficult. A very difficult, faith-challenging time in your life. What do you think reading Donna's prayer card might mean to her?
Prayer must be important to her, but if I prayed with her, I would be a hypocrite. Even talking about this is making me feel bad, like I did after my brother died.
Well, praying for Donna today might be a very generous way to offer her support for her health and wellness and to show her empathy. But if it makes you uncomfortable, there are some other options. Let's sit down and think about some of these ideas. Would you be comfortable suggesting a moment of silence? Or perhaps we could ask Donna's nurse to contact one of the chaplains.
And that is it for the role play. And then I'm going to go into identifying legal and ethical issues of concern. This is a really hard one for legal and ethical issues because there's a lot of gray area around the subject. So legal and ethical issues about praying with a patient and encouraging a young student to explore their own thoughts and feelings about prayer can be touchy, often not brought up until the situation occurs. Legally, there is no law that states you should or shouldn't pray with a patient. If a provider is doing what's best for the patient or in the best interest of the patient, they would inquire about the religious status, or at the very least ask the patient if it's okay to pray with them, if comfortable, and give the patient the option to opt out if they are uncomfortable. Ethically, if a patient is not comfortable with prayer or spirituality's discussions and does not want to be prayed with, this is their right to say, "I am not comfortable," without feeling judged or viewed differently. As a provider, if a patient is requesting prayer, it is okay to say, "Let me get someone who can pray with you." So the legal and ethical issues that we were discussing are very gray. There's no definitive right or wrong answer. You kind of need to look on an individual basis with the provider, student, and or patient.
Mine is the next section, and it's on identifying an ethical decision-making framework or model that we want to use to resolve this problem. Ethical decision-making models were developed to assist those who are experiencing difficulties in applying ethical standards in professional practice. Frameworks for ethical decision-making are not scientific. Ethical decisions would be easy if they were always clear-cut, but very often they're not. They require thought, self-awareness, and reflection. Nurses and nurse practitioners make decisions every day that must take into account laws and ethical standards. An ethical framework is not a legal framework. Ethics constitutes appropriate conduct and can be thought of as an ideal set of principles. This NP student and her preceptor each came to the clinical setting with varying life experiences and different degrees of education and professional experience that would influence their interactions with patients. But to ignore Ruth's spirituality would be to ignore a central piece of what it means to her to be a patient. So as a group, we decided on the ethical framework used by developed by Corey, and Callahan. The steps are intuitive, practical, and easy to use. There's 8 steps. Step 1 would be to identify the problem, which is, must the student pray with the patient? Step 2 is to identify the potential issues. The student feels like it would be hypocritical and the patient has not made an unreasonable request. Step 3 would be to review relevant ethical guidelines, and that may depend on the culture and mission statement of the clinic or hospital. Step 4, know relevant laws and regulations, and this is not a legal issue. Step 5, obtain consultation. The nurse manager and chaplain are good resources. Step 6 would be to consider possible and probable courses of action. Find someone to read the prayer card to her that's comfortable doing so. Step 7 would be list the consequences of the probable courses of action, which would relieve the student of the responsibility and would meet the needs of the patient. Step 8 would be to decide on what appears to be the best course of action. Preceptor, student, and possibly the manager would need to meet to make this decision. So application of these 8 steps will be explored in depth in the next section.
And that's my section. So we're going to talk about options for handling the problem. So what is the problem? The problem is that the nurse doesn't feel comfortable praying with the patient, but the patient wants the nurse to pray with her. And the student needs to is recognizing that she has an issue with praying with her patients. And what can we do? What can the nurse do? What can the preceptor do to fix it? So we're going to identify the issues involved. That's step 2. Identifying what the student and the preceptor's personalized feelings are about prayer. And the patient's right. The patient has a right to have her sexual issues addressed. But it is the right of the provider, the student, to not go against her personal beliefs if she's not religious. And there is a difference between the patient and the provider's religious preference. So how are we going to address those differences in personal feelings to the patient? And the ethics code. So prayer is a coping mechanism for patients, despite how we might feel as staff or as preceptors and students feel about it personally. And it can help them heal. It can help them relieve stress and anxiety. So it's going to help Donna's anxiety much better than lorazepam if she can feel ease on her mind. But a nurse shouldn't go against her beliefs. If the student is not religious and she's agnostic, she shouldn't be praying to God if she doesn't believe in a God. But however, they should ask somebody respectfully and not just say, I'm not going to do that because I don't believe in that. It's hard for the patient sometimes to pray on her own, especially if she's diagnosed with COPD and she has a hard time breathing. It's hard for them to concentrate. So easing their mind by praying with them or finding somebody else to pray with them will save nursing time because it will reduce the patient's anxiety. If we ignore or refuse to pray, that's being insensitive, and that's not ethical for the patient. But acknowledging that you can't meet the patient's needs and respect their wishes, that's the ethical thing to do. You want to tell the patient that you're aware that prayer is comforting to them, but you don't believe in it, and it's not ethical for you as a non-religious person to perform the prayer, and ask if you can find somebody else more qualified, the chaplain, their family members, maybe the patient's nurse, who is comfortable with meeting their needs and in prayer. And number 4, knowing the applicable laws. Like we talked about before, there's no legal law for this. It's a personal choice and it's a gray area. Number 5, obtain consult. Speak with the preceptor, which she did. Speak with the floor manager to see if this situations came up before and what resources are available, such as a chaplain, a volunteer, the nurse, the family members. And if there is a chaplain, request for them to come and minister to this patient. Number 6, so what action can we take? Tell the patient you don't feel comfortable praying with her, but ask the preceptor or the chaplain in your place. Have a moment of silence with the patient. That way you're not praying to any God, but you're allowing her to have her moment of silence, and you may be ministering in your own way with your moment of silence. Tell her you're not religious, but will hold her hand while she prays, or possibly, if you feel comfortable with it, read the card for her. And ask the patient's nurse to come or see if the family is available. Consequences of these actions. Will the patient look down on you or judge you for not wanting to pray with her? Will the student feel that her personal beliefs have been compromised if she would pray with the patient? Will not praying with her be against the patient's rights? Will it make the patient feel sad and put down and not cared about? And can the student forgo her personal feelings and speak the words of comfort off the card that the patient needs to hear? So choosing the best action, this is not always easy. Speak with the student and see, is she okay with the moment of silence of the patient or speaking the words off the card? And if not, can the preceptor go in the room and pray with the patient? Or maybe have the chaplain come and schedule a daily meeting between the chaplain and the patient. And then talk to the student and explain how prayer can help relieve stress and promote healing in our patients. So I'm going to wrap up and say who completed each section and then open it up for questions. So Sarah read our scenario, and the role play and enactment was with Sarah and Aaron. And then Aaron identified our legal issues and ethical issues. Josephine talked about the Corey, and Callahan framework and talked about how we're going to resolve this problem. And then I went through all the framework steps as she described with what this nurse and preceptor and student can do about this situation. Any questions?
I don't really have a question, but I did want to comment about your role play. I liked that. I really liked that the preceptor explored with the student reasons why she was uncomfortable praying with the patient. So it gave the student an opportunity to just kind of share about her own experiences with religion and belief and stuff like that. And it kind of took this like non-judgmental tone away from the conversation. I liked that a lot. And I liked the recommendation of getting someone else to pray with the patient or the chaplain if the student was uncomfortable with that. That was really good, a great solution. So you didn't force the student to go against her own beliefs and do something that was really uncomfortable for her, but then at the same time you address the need of the patient in providing a means for her to pray. So good job. I thought it was good.
Yeah.
Thank you, Summer. I agree with you there. I'm glad that we chose some of that dialogue. The interaction between the preceptor and the student, because the preceptor is in that role of precepting, we kind of felt like you have to be very gentle in talking about your getting your student to explore some of their beliefs without being too prying, because I think there might be a reaction of like, oh, you're uncomfortable? Oh, well, let's just not go there. And then the whole thing gets shut down, and then the patient doesn't get extra resources, or it's just shunted to somebody who's more comfortable with it, but then it's really not talked about. So I totally agree with you that if you can be sensitive to the person who, that you're interacting with, and in this case it was the student, but it could be anybody, and at least be able to explore some of those uncomfortable sensations, then you find out a lot more about that person, about their reaction, about how they could work through this. And then that student actually is going to be better prepared for the next time this happens, because it's a commonality in medicine for there to be religion or there to be spirituality that is interwoven with our interactions with our patients. So yeah, thanks for your feedback.
I thought it was a great idea to offer if the student was comfortable with the moment of silence, because even if the chaplain came up and still did the prayer, if the student felt bad, or maybe, she could still have a moment with the patient if she was comfortable with that and still kind of not feel like she was putting her off to somebody else. So I thought that was a good idea.
Yeah, because maybe the student had a really good rapport with the patient in a way that the patient felt comfortable asking her to do that. And so then that's a way for the patient to keep that relationship with, or the student to keep that relationship with the patient, which is really important.
Good.
And I have one last thing. I think it's important that we realize, like, with this situation, it's kind of a double-headed sword with the ethics, because you have the student on one hand who doesn't feel comfortable, and then you have the patient's belief on the other hand, and you have to respect both of those. So thinking that how prayer does help people, and it may not be actual prayer, but it may be whatever whatever helps them to ease their anxiety can really help. And in some ways, this whole scenario helped the student to kind of open up and figure out more about herself and how she really felt in her own life situations. And this is something that, of course, she will see again as a nurse or nurse practitioner, whatever kind of a student she is. So it's important for her to kind of come to terms with her own personal beliefs and what she feels comfortable with and how to properly address it in the future, so she doesn't, nobody wants to be rude or coming across as unfeeling with their patients, and we have to respect both, that to accept both sides.
Right, because maybe she had no idea why she doesn't like prayer, or, you know, she just knows she doesn't like it, but, you know, she has a bias against it, but she doesn't really know why. So when the preceptor said, you know, can you tell me a little more about it? And then she said about her brother. So it caused her to dig a little deeper of why, like, what the true cause of her not liking prayer was.
You know, this was an easy one for me because that scenario was actually my daughter-in-law, and that is what happened and why she doesn't believe in God. So sometimes I wonder if by throwing it out there, it gives her an opportunity to kind of discuss, maybe she's not as comfortable with, you know, just not believing in God as she might say, but it does open up the lines of conversation.
I think it's important too, because this isn't the first time that the student this isn't the last time that the student will encounter this on her journey. And I think helping her kind of understand for now that, you know, this is how you handle it will probably really guide her in the future, because, you know, this is her, this is her career and livelihood. And, you know, this is not the first time that a patient is going to ask her for this. And that way she knows in the future too, how she should respond by either getting a clergy member or, you know, the moment of silence or, you know, something of that nature. So I think it's really helpful in setting her up for future success as well. And just kind of providing that guidance in that learning environment so that she can apply that later on down the road. I think it's almost, you know, just as important as clinical skills, teaching someone how to relate with patients. And sometimes that's, you know,
even
how
uncomfortable stuff.
Right, even the uncomfortable stuff, and those are, you know, the issues that we see in nurse practitioners every day. And, you know, you go into a patient's room and you may not be completely comfortable, but, you know, I think this is just as important as teaching someone, you know, how to do, you know, a physical exam or a pap smear, or, you know, something like that. I think it's just as important. So I really liked the way that you guys handled this. I think it was appropriate. Thank you.
And probably for Honest, this is going to be like the easiest situation that she's in. You know, she's going to run into like people who refuse medical treatment because it's against their religious beliefs or something like that. And it's going to be heartbreaking for her in some scenarios. So it's a good lesson.
Yeah, good work, guys. Thank you.
Are you done? Do you want us to go?
Yeah, I think we're done.
All right. Group 2, you guys ready?
Yeah.
Okay. Take it away, Amanda.
All right. So we had scenario 9. Student nurse practitioner Nancy is starting her clinical morning in the GYN clinic. She's performing well routine exams. Upon entering the room, Nancy recognizes the patient, Elizabeth, as her daughter's teacher. Elizabeth politely states that she would feel more comfortable if you, the preceptor, performed the exam alone. Nancy pleasantly agrees and excuses herself from the exam room. She returns to your office to wait for you. When you return to your office, Nancy is reviewing the patient's chart. "Look at this," she exclaims. "It says here that Elizabeth is in a lesbian relationship. She teaches at St. Jude's Elementary School, and I know for a fact that they would not look favorably on that information. How do you handle this situation?" So it will be Summer and I doing the role play here, and I am the nurse practitioner, and Summer is Nancy, the student. "Nancy, it is inappropriate for you to be looking through Elizabeth's chart."
Why? She's a patient here.
"The patient asked that you not be involved in her care because you know each other outside of this office."
Yeah, but she's still a patient here.
Correct. However, patient charts are confidential and only the healthcare providers that are a direct part of the patient's care should view them. You were removed from this patient's care team, therefore you do not need to view her medical information.
Okay, but the school wouldn't approve of Elizabeth being a lesbian.
That is confidential information protected by HIPAA. Are you aware of HIPAA?
Yeah, but this isn't about her medical information. This is about her lifestyle.
Where did you find this information?
In her chart.
Exactly. Anything contained within a patient's chart or interactions between healthcare professionals and a patient is protected. This includes information such as the patient's demographics, like age, marital status, sexual orientation, and all medical information. Do you know the consequences of violating HIPAA?
I think I remember that it can be reported to the state.
It's far more than that. You would be subject to discipline from the nursing board, including losing the ability to practice. In addition, HIPAA violations can result in fines and even jail time.
I just don't agree with that kind of lifestyle.
Nancy, I know that this is uncomfortable. However, as a nurse and a potential nurse practitioner, you should treat all patients equally. Failing to do so is discrimination. Age, sex, gender, sexual orientation, religious views, political affiliations, and socioeconomic backgrounds are just all pieces of our patients, and we as healthcare providers must protect everyone from discrimination. It is always our right and always our responsibility to do no harm. This includes protecting our patients' basic human rights and their right to privacy.
Okay, I won't say anything.
Nancy, this is so serious. I think that it would be a good idea for you and I to meet with your clinical supervisor to discuss this issue further. In addition, I would like you to do research on HIPAA and HIPAA violations. Specifically, I would like you to summarize a case of a HIPAA violation, the aftermath of that case, and a self-reflection on your own personal bias involving those in the LGBTQ community. The personal reflection will be communicated in confidence with me. In addition, I feel that I should also speak with your dean of students so that you may understand the severity of this threat to Elizabeth's life and career.
The end. Okay, so I'm going to do question number 3, identify legal and ethical issues of concern. So the first one we said was the judgmental attitude and tone of the student. Nancy's judgmental tone and behavior are an indicator of her present and future actions. There should be a grave concern about this patient's information. It is vital to discuss this at length with both Nancy and her clinical supervisor for the term. In addition, this should likely be reported to the dean of the program. Not to get Nancy in trouble, but just to reiterate the severity of the concern. The judgmental attitude is discrimination. Discrimination is defined as the unjust or prejudicial treatment of different categories of people or things. The judgmental tone and attitude of this student is only a small piece of this puzzle. This clinic should seriously consider not continuing to serve as Nancy's clinical site, as this kind of attitude can result in dire consequences for the clinic and its patients. The threat of exposure of Elizabeth's sexual orientation could result in workplace discrimination from the school where she teaches. Legally, this could result in a lawsuit and subsequent fines, not to mention the damage of the clinic's reputation within the community and Elizabeth's personal and professional life. LGBTQ discrimination is unfortunately still a common practice in many arenas of life. In 2016, 1 in 4 of LGBTQ individuals had experienced discrimination in the workplace. That was from Singh and Durso. Quote, when someone shows you who they are, believe them, unquote. The second thing we identified were her issues of discussing patient in personal tone and manner, which was kind of gossipy, which is not only unprofessional, but unethical. C, and then the HIPAA violation. Because the student did not see the patient, there's no reason for the student to be looking in the chart. If this information was made public knowledge, it could have impacted the patient's livelihood, her family dynamics, and her overall well-being, and holistically looking at her health, her overall health. Legally, a violation of HIPAA law is considered criminal with financial penalties, termination of employment, and even imprisonment. The offense is one of the most serious kind within the healthcare setting.
Okay, so I'm going to cover number 4, which is the ethical decision-making framework or model that we used for the problem. The model that our group decided to use for the problem was the 6-point framework by Sukera and Watling. This framework includes 6 key features and associated strategies. The first feature of the model is creating a safe and non-threatening learning context. Strategies for this include approachable instructor, sufficient time, and respecting confidentiality. The second feature is increasing knowledge about the science of implicit bias, and this includes interventions that increase recognition of implicit bias, covering the neuroscience, cognitive psychology, and types of bias. The third feature is emphasizing how implicit bias influences behaviors and patient outcomes, and this includes aligning the interventions with education on health disparities, clinical decision-making, and errors in patient safety. The fourth feature is increasing self-awareness of existing implicit bias using implicit association tests, reflection exercises, and identity exercises. The fifth feature is improving conscious effort to overcome implicit bias, and this feature includes strategies such as metacognition, mindfulness, and self-regulation and self-monitoring that facilitates the learner to think about their thinking. And the last feature is enhancing awareness of how implicit bias influences others. And this feature helps emotionally link the patients and providers and helps protect against stereotyping. Strategies for this feature include social contact, perspective taking, and empathy.
And then I'm going to do the last question and describe options for handling the problem using the SELECT framework or model and how you decided on your group-specific responses. So when handling this situation, we use the A 6-point framework, as Clarissa mentioned. The preceptor should start with providing a climate of safety and non-threatening learning environment, openly talking about how the conversation on biases can be uncomfortable. The preceptor should allow enough time for the full conversation and not be rushed. The preceptor should have a discussion with Nancy on biases and how it affects patient care and how it can restrict being open-minded in different views. Reflective activities and exercises that can increase self-awareness of existing biases include role play and social contact with matched patients with live experiences may help enhance views in Nancy. Improving and overcoming implicit biases allows awareness of how a bias can affect others. So our group decided on this framework because these 6 points provide the most direct approach to follow on how to deal with the ethical dilemmas and biases when they arise. This framework helps to shift the learning experience away from guilt and move it to a more positive, proactive outcome without the risk of personal offense. In this case, this option would help the student nurse practitioner to increase awareness of her personal biases and behavior of labeling Nancy, the patient, with potential negative outcome. This in turn would help the student nurse practitioner to grow professionally and accept the patient as an authentic member of society.
Okay, I'm gonna go over the roles of our group during the project. So Kristen, she initiated a group discussions with email. She participated in group online meetings that we had. She answered questions 4 and 5, gave constructive feedback regarding the rest of the group questions and the role play, and she helped with Google Play. Amanda, she worked on questions 1, 2, and 3 of the group work. She created the role play, participated in group online meetings, gave constructive feedback regarding the rest of the group's questions. Carissa participated in the group online meetings, answered questions 4 and 5, gave constructive feedback regarding the rest of the group questions and role play. And then Summer was the group leader. I initiated with group 1 and organized Google Air and Hangout, worked on questions 1, 2, and 3, gave constructive feedback, and participated in the group online meetings. Okay, we are done with ours. Any questions or comments from group 1?
You know, I have a comment. As you were doing the role play, it was very, very concerning that the student kept pushing back. Do you think that this, I know that I thought it was really great that the way that preceptor handled it, and it sounded like she was going to take it further. And I'm not certain that this person would be a good nurse practitioner. Did anybody else feel that too? I mean, you would think if somebody called you on it, you would instantly say, "Oh, I'm so sorry. I understand." But instead, she kept saying, "Well, she's a lesbian. Well,
Yeah.
I don't like that." So, what do you think?
And when we, when I kind of, because I did most of just the creating of the role play, and I thought about taking it to where, Summer, which she was the nurse practitioner student, to where she would just say, "Oh yeah, I totally recognize it." But I honestly feel that if the nurse practitioner student, Nancy, was going through this patient's chart and thought enough to seek this information out, one, and two, to actually go as far as saying, hey, this person's place of employment, this St. Jude school, is really not going to like this, that this patient is a lesbian. I really feel like she probably wouldn't just drop it immediately. And so that's kind of why we had her push back a little bit, because she just obviously she doesn't understand the severity of this. And I think that's why too, we talked about in our group, if we were being a little bit too severe by going to the clinical supervisor and also going to the dean of students. But honestly, like we had talked about, it's something that could sincerely affect this patient's life and, her career, her livelihood, the way that, she interacts with her family and her peers. And, and obviously this would be a huge detriment to the clinic and legally. And I agree with you. I don't know that this, and that's why we kind of brought it up too in Summer's question about how, we don't know that the clinic should continue to kind of sponsor Nancy, because it's one of those things where the severity of this it's a rapidly falling snowball effect that could really impact the future of this woman. So
I agree with you, Amanda and Josephine. The severity, it's really serious. And so I'm really glad that you guys talked about kind of the multi-step process that you were going to have the student go through. Research HIPAA, write me a report, tell me how severe this was. But certainly that's not enough. I think going to the supervisor, even talking to the dean of students, is a good idea. So she really needs to demonstrate understanding of knowing how severe this type of talk even is, or to have that attitude, because definitely I agree that she may not be provider material if she is this flippant about that kind of information.
And I have to say, I'm kind of someone that believes in second chances and being a preceptor and all that stuff. I feel like your role as a preceptor is to identify the problem, tell the student why it's so severe, advise the student to change, but then you can't really change the person, right? You can't force the student to become someone that she's not. And then, making sure that that's all documented and clear. And then I feel like if the student decides not to change, that behavior will follow her into other clinical settings. And then she will probably, if she doesn't change, won't be a good nurse practitioner and she'll fail. I mean, she's going to get herself in trouble, So
I like the emphasis that you guys put on HIPAA, because I feel like people don't take that seriously. I mean, you're in a hospital setting or a clinic setting even, and people are just randomly talking about people and, open areas. And I feel like that's not something that's taken seriously. And so I feel like that, your student isn't taking, oh yeah, whatever, it kind of blowing you off. So I do like that you guys really put a lot of emphasis on, do you even know what this means? Do you even understand what it means to have a HIPAA violation? Because I feel like people are like, oh yeah, they'll report me. No big deal. No, it's a big deal. And I feel like people don't take it seriously like they should. So I think that was good.
I think we need to also let the patient know that her privacy was violated by the student, so that she is aware. I mean, I know that's what we do in the clinic that I work in, is if something like this happens, you're going to notify the patient of a HIPAA breach, and maybe not who violated your privacy, but they're definitely going to need to be made aware.
That's the first I'd ever heard of that, of notifying a patient. That surprises me.
Yeah, I don't know really how that would work, because I mean, it's obviously, if after all of these discussions and talking with the student and talking with the clinical supervisor, if there was a serious concern still, I don't know how that would actually look on look, going to the patient and saying that this happened. Obviously, if you went to this patient, the student nurse practitioner could no longer be in this clinic, you know, because you're saying, oh yeah, she violated your HIPAA, but we've kept her on as a student. You know, that's obviously that would terminate that relationship. But you know, that just thinking about how to go about talking to this patient about it, I'm not sure. What do the other group members think about that?
So
Yeah,
I don't.
Oh, sorry.
I don't think it was very clear that this student was not welcome to have a part of the patient's, be a part of the patient's care team. It sounded to me more like, you know, the patient's not comfortable having you in the room right now. And I've had that happen many times. It's not that they don't necessarily want me to be a part of their care team and have input. It was just, hey, you know, this is something a little more private. Can I have a little one-on-one at this moment? So I did think that the meeting conversation was super clear. Like, you are not welcome to be a part of this patient's care period. Under discussion is just, it's at this visit, the patient's requesting that you don't come in. So I feel like in that case, the student maybe didn't have a clear understanding that they shouldn't be looking in the chart. Because if you know, I had a patient, I probably would have looked in the chart before I even went in the room, you know, try to, you know, learn a few things about them, see what their past medical history is, things like that. So I don't know that you would actually call that a HIPAA violation at that point. If the student takes it further than that and doesn't heed your warning, I feel like then that's a HIPAA violation. I don't think that her just kind of doing some research and looking into the patient.
It's not so much as, you know, because the scenario, you're right, wasn't, I don't know that it made it perfectly clear to the patient or the nurse practitioner, that student, that she wasn't supposed to be involved in the care. I think it's more the violation of HIPAA involves the threat of going to, you know, this patient's school and workplace and saying, you know, these things. So at that point, obviously, she's in direct violation of HIPAA, and then, you know, she shouldn't be looking at the chart at all at that point, from that point going further. Yeah. So I think too that, you know, it's kind of one of those things that you have to see how she would react with all of this kind of intervention. And like Summer said, I don't know that this can be changed, you know, in someone. Can you instill the sense of non-discrimination for, you know, things in someone if they already, you know, have this up front?
It's hard to believe that she got through nursing not realizing that this was a real problem.
I feel like you guys could have a similar conversation with her that we did with our, you know, our student about the prayer. It's like, what is it about lesbians that makes you uncomfortable? Like, what is it about this particular set of people that makes you think that, you know, they're that much different from you are? I mean, it's just, you know, a sexual preference. It's not that they're a bad person. So what is it about them that makes you feel this way? So kind of having the student explore their own thoughts and feelings about why, you know, why she's having that.
Yeah, that's why I think we put the self-reflection in the list of things that the student was supposed to do for the preceptor to bring that out. So that was in there.
Because all in all, she's got to explore her own biases.
Yeah, she does. I think your point, Josie, you know what I was thinking as the preceptor was, I felt like going back to the dean was important because I felt like it was a school concern. Like, why is the student coming into clinical with not a really severe understanding of what HIPAA is about? And I feel like as a teacher, not that preceptors don't have that role to reinforce that, but you know how like we learned about FERPA and stuff like that. Like, I feel like part of clinical is teaching your students about HIPAA.
Right.
So.
And like it just, and like Josephine mentioned, how did she make it through nursing? You know, how did she get this far with this kind of attitude? And admittedly, you know, there are nurses out there, obviously, who have this personal bias, and that's unfortunate. But how did she expect to make it through GYN clinical setting without experiencing someone, you know, and maybe it's because she just knows this person and it's her daughter's teacher, but yeah, it was a tough it was a tough scenario, and I'm happy that we actually had it, because it had me thinking about like nurse practitioner students that I've had, like, and I see, lesbian patients in my office, obviously, and I see transgender individuals, and, I think this is something that I should actually bring up and, talk about diversity and women's health. So.
Yeah, I was thinking that too. This is something I should bring up to my students too. Like, I don't even think about that stuff, that people would have those type of biases.
Well, I think now in the world that we live in now, there's a lot less biases, but there are still a lot of people out there who are very strong in their traditional, whether it's religious beliefs or whatever, to where they've been raised, and they look down on people who aren't like them. And fortunately, a lot of that is changing, but there is still a lot of that out there. I think more maybe in the small communities, and it sounds like maybe this is a small community because she knows her in the school setting. And with those small communities, people find out everything about you. So I think even in that, HIPAA is much more of an important aspect, because you don't want everybody knowing your business. And to find out that she's a lesbian, you can't just find that by opening the chart. You have to dig for that information.
I often make this joke that I seriously, I cannot go to CVS in this town without running into at least 10 patients. And, I have toddler babies that are shown to me, and look, you delivered this baby. Looks just the same, but it's one of those things where, and I've actually had patients say, you didn't say anything to me. I walked past you in Kroger and I was waiting for you to say hi. And I said, I don't like to be the first to acknowledge people in public, because it's not my decision to approach me and say, so it's right. In the small town, it's really hard. I delivered a patient yesterday who I've delivered every baby in that family, from their sisters to her sister-in-law for the past 4 years. And so, I get the sister-in-law that's sending me, messages. Hey, how's my sister-in-law doing? I can't tell you that. What do you want me to say? So it's harder in a small community. I completely agree with you, especially something like this. Could be tragic for Elizabeth if this is, brought to the forefront for her.
It could also be tragic for that nurse practitioner student. And I don't think she has the good sense to realize what danger she's in of losing her career and jail time. I guess I wasn't really aware of that.
I read a case about I wish I would have written it down, because I searched through some HIPAA cases just to see kind of, and there was a case where a nurse kind of violated this, and this was not her first offense, and she had to pay a lot of money. And because it was such a severe thing, she then got civil suit against her, and then it was a big ordeal. And I think a lot of that we don't realize how big of a deal it actually could be, especially like Erin said, with seeing something like this and communicating it to people, and then in small towns and at clinics, and them just saying, oh yeah, let's just talk about this person because we know them from down the street. And in a smaller clinic, it's sometimes HIPAA isn't taken seriously.
Yeah, Josie, when I was researching about HIPAA, I didn't know about the jail time either, and they said like up to a year.
In a severe your first offense, right?
Yeah, get jail time. Oh. Okay, are we done? Thank you so much, Group 1, for all of your comments and feedback. That was great.
Yeah, thanks, everybody.
Thank you.
Yes, anything else that needs to be said before I stop the broadcast? I think we still stay on. I just stopped the recording. Nope. Okay, I will do that.